In this lecture, we'll be discussing about anterior uveitis. Now, uvea basically consists of the iris, the ciliary body, and the choroid. Okay. Now, the ciliary body is again divided into two parts: the pars pliccata of the ciliary body and the pars plana of the ciliary body. Now, anterior uvea refers to the iris and the pars pliccata part of the ciliary body. Okay, now let's look into the definition of anterior uveitis. Remember, we're discussing anterior uveitis, also known as iridocyclitis. Note the definition. It is the inflammation of the uveal tissue from iris up to the pars pliccata of the ciliary body. Now, it can be divided into iritis, that is the inflammation predominantly affecting the iris, or iridocyclitis, that is the iris and the pars pliccata of the ciliary body is equally involved, and finally anterior cyclitis, that is the pars pliccata of the ciliary body is mainly involved. So remember, anterior uveitis, it is the inflammation of the uveal tissue from iris up to the pars pliccata. Now you can see in this diagram again, this is the iris, this is the pars pliccata, and this is the pars plana, and this continues as choroid. Now for our exams, the most important is iridocyclitis, that is inflammation of the iris and the pars pliccata of the ciliary body. Now let us look into the etiology of uveitis or iridocyclitis. Now it can be divided into infectious causes and non-infectious causes. Now under the infectious uveitis, we have bacterial uveitis, which can be seen in conditions like syphilis, tuberculosis, and leprosy. Then we have viral uveitis, which is seen in herpes zoster virus infection and cytomegalovirus infection or dengue infection. Parasitic uveitis seen in toxoplasma and cysticercosis, and finally fungal uveitis seen in candidiasis and aspergillosis. So this is the infectious uveitis. We have bacterial, viral, parasitic, and fungal. The non-infectious uveitis, it is seen as autoimmune uveitis in multiple sclerosis, sarcoidosis, rheumatoid arthritis. Then we have collagen-related disorders like disseminated lupus erythematosus. Then we have atopic uveitis, that is due to airborne allergens. Fourth is traumatic uveitis following ocular trauma, and fifth is it can be associated with skin lesions as well. So remember, we have infectious uveitis and non-infectious uveitis. Infectious uveitis, we discussed bacterial uveitis, viral uveitis, parasitic uveitis, and fungal uveitis. And in non-infectious uveitis, we discussed autoimmune uveitis. Now uveitis seen in collagen related disorders like disseminated lupus erythematosus. Third is atopic uveitis due to airborne allergens, traumatic uveitis following ocular trauma, and finally associated with skin lesions like psoriasis. Now the importance of discussing the etiology here is that when we are taking the history for a uveitis case, we should confirm the negative histories for the infectious uveitis and the non-infectious uveitis, and this can be understood by asking the patient. So suppose if the patient might have had tuberculosis or leprosy, we have to mention that there is no history of cough or breathlessness. And parasitic uveitis, toxoplasma, it is seen associated with pets, so we have to ask the patient, do you have any history of pets? Then autoimmune, you have to ask the patient, do you have any is there any history of autoimmune disorders like sarcoidosis, or is there any joint pain to rule out rheumatoid arthritis? Then skin lesions like psoriasis or any other skin lesions. So this is the importance of discussing the etiology. So again, just for revision, we have infectious uveitis and non-infectious uveitis. Infectious uveitis, we discussed bacterial, viral, parasitic, fungal uveitis, and in non-infectious we discussed the autoimmune uveitis, the collagen related disorders, atopic, and traumatic uveitis. Now finally we have something known as the masquerade syndrome. Now this is basically a clinical presentation of uveitis which are not due to immune related entities. Okay, so masquerade syndrome is basically uveitis which is not due to immune related entities. Now this can be again divided into non-neoplastic masquerade syndromes and neoplastic masquerade syndromes. Okay, so this is the etiology of iridocyclitis. Now let us look into the clinical features. Now the symptoms of acute iridocyclitis. Okay, so iridocyclitis can also be divided into chronic and acute, and the commonly asked for our exams is acute iridocyclitis. Now let us look into the symptoms. We have pain, redness, photophobia, lacrimation, and defective vision. The patient can come with any of these. Okay, now the pain is dull, aching, throbbing sensation which is typically worse at night, and the pain may radiate along the branches of the trigeminal nerve. Now the redness is seen as a circumcorneal congestion. Then we have photophobia, lacrimation, and defective vision. So these are the clinical features, the symptoms the patients present with these. The usual symptoms are pain, redness, and defective vision. Now coming to the signs of uveitis. So we have corneal signs, anterior chamber signs, iris signs, pupillary signs, and finally changes in the lens. So this can be discussed, like if you look into this diagram here, we have, so this is how the light rays go. We have first the corneal signs, then the anterior chamber signs, then the iris signs, then the pupil signs, and finally the changes in the lens. So let us look into each one in detail. Now the corneal signs, the important ones are the circumcorneal congestion, edema, and something known as keratic precipitates or KPs. The anterior chamber signs includes aqueous flare, aqueous cells, and hypopyon. The iris signs, waterlogged iris, muddy in color, presence may or may not present with iris nodules, and finally posterior synechia. The pupillary signs, we have a festooned pupil, and there is decreased pupillary reactions, and changes in the lens, complicated cataract, pigment dispersal on anterior capsule. So these are the signs. So we have to remember corneal signs, anterior chamber signs, iris signs, pupillary signs, and changes in the lens. Now we'll be discussing each in detail. We have to elaborate each of them in detail for our exams as well. Now this diagram can be drawn, and this shows the circumcorneal congestion, then the festooned pupil, keratic precipitates, and posterior synechia. Okay, so this is the diagram for the signs of uveitis. Now let us begin by discussing the corneal signs. So we have circumcorneal congestion, corneal edema, and keratic precipitates. Now keratic precipitates, these are the pathognomic sign of anterior uveitis. Now what are they? They are proteinaceous cellular deposits occurring at the back of cornea. Now these are because of the inflammation in the iris. There is exudation of the inflammatory cells and certain proteinaceous substances, and these become aggregates which get arranged in the back of the cornea. So this is the keratic precipitates. So again, these are proteinaceous cellular deposits occurring at the back of cornea, and you can see in this diagram here. They are usually arranged in a triangular fashion, occupying the center and the inferior parts of the cornea, as you can see in this diagram here. So again, what are keratic precipitates? They are proteinaceous cellular deposits occurring at the back of cornea, and they can be seen as arranged in a triangular fashion, occupying the central and inferior portions of the cornea. Now there are many types of keratic precipitates. The two important ones are mutton fat keratic precipitates seen in granulomatous uveitis, and granular keratic precipitates seen in non-granulomatous uveitis. So these are the corneal signs. Now coming to the anterior chamber signs, number one, we have aqueous flare. Now this is the earliest sign of acute anterior uveitis. Okay, so the earliest sign is acute aqueous flare. Now they occur due to the leakage of proteins into the aqueous humor from damaged vessels, and when the light is passed, because of Tyndall effect, a flare is seen. Okay, so this is aqueous flare, earliest sign of acute anterior uveitis, and because of the leakage of proteins into the aqueous humor from the damaged vessels, when light is passed, because of Tyndall effect, a flare is seen. So this is aqueous flare. The second is hypopyon. Now hypopyon is basically sterile pus in the anterior chamber. Because of the inflammatory process, pus can be seen, and this pus in the anterior chamber is known as hypopyon, and this is a feature of granulomatous uveitis. The third is the anterior chamber depth. Now for now, just remember, I'll explain it later. We have funnel shaped incomplete posterior synechia with iris bomb, and deep anterior chamber in total posterior synechia. We'll come back to this later. So again, the anterior chamber signs, the important ones are aqueous flare and hypopyon, and there is some aqueous cells may also be seen. And regarding the anterior chamber depth, we'll come to it later. Now the third, so we finished with the corneal signs, the anterior chamber signs, and now coming to the iris signs. Now because of the edema, the iris becomes waterlogged. The color is muddy brown, and the third feature the third iris sign is the presence of iris nodules. Now this is only seen in granulomatous uveitis, and there are two types. We have the Capes nodules and the Busaka's nodules. Now the Capes nodules, they are the smaller ones and it is seen in the pupillary border, and Busaka's nodules are quite larger and they are not seen, they are seen away from the pupillar border. So this is the difference between the iris nodules, and this is a real life photograph, and this here is the Capes nodules. Next we have posterior synechiae. Now this is the important iris sign. Now posterior synechiae, what are they? They are the adhesions between the posterior surface of the iris and the anterior capsule of the lens. Okay, so you can see in this diagram, this is the iris and this here is the lens, and the adhesions between the posterior surface of iris and the anterior surface of lens is known as synechiae or posterior synechiae. Now morphologically they can be of the following types. We have segmental posterior synechiae, that is the adhesions only occur at certain points. The second is annular or ring posterior synechiae, where the entire, that is a 360-degree addition of the iris to the lens, as you can see in this diagram here. And the third type is total posterior synechiae, that is the complete posterior surface of the iris is adhered to the lens. Now we've understood what posterior synechiae is. Now let us go back into the anterior chamber depth signs. Anterior chamber depth sign. Now in annular or in ring posterior synechiae, what happens is there is a blockage between the aqueous flow. Aqueous humor, it is produced from the ciliary body and it flows like this. Now because of this blockage, aqueous humor collects behind the iris and pushes it forward. Okay, and this leads to iris bomb formation. Okay, and because of this, a funnel shaped anterior chamber is seen, and this is why we've mentioned here a funnel shaped anterior chamber depth is seen in complete posterior synechiae with iris bomb formation. In total posterior synechiae, the entire posterior surface of the iris is adhered to the lens, and hence the anterior chamber becomes deep, and that is why we've mentioned deep anterior chamber in total posterior synechiae. So these are the iris signs. Remember, waterlogged, muddy brown iris nodules may be seen. We have Capes nodule and Busaka's nodule, and the most important sign is posterior synechiae, which are the adhesions between the posterior surface of the iris and the anterior capsule of the lens. Another sign that can be seen is neovascularization of the iris, and this is seen in chronic uveitis. So the important ones are posterior synechiae, muddy brown, waterlogged iris, and iris nodules. Now coming to the pupillary signs, because of the toxins released due to the inflammatory process, it causes ciliary spasm, and as a result the pupil becomes narrow. So this is the first pupillary sign. Now a festooned pupil is seen in segmental posterior synechiae once the pupil is dilated. Okay, so segmental posterior synechiae, we've mentioned that these are basically the adhesions at certain points. Okay, so let me just draw a diagram for you guys to understand. So this is our pupil, normal pupil, and it is adhered to lens at these points. Now suppose a mydriatic is applied and the pupil is dilated, but because of these dilations, this is how the pupil will dilate. Sorry. Okay, and this here is known as a festooned pupil, which is seen in segmental posterior synechiae. Now the next pupillary sign is decreased pupillary reactions, and fourth one is occlusio pupillae. Now occlusio pupillae is the pupil is completely occluded due to the arrangement of exudates across the entire pupillary area. So if you look into this diagram, the normal diagram, okay, so here because of the exudates due to the inflammatory process, these exudates come and arrange them across the entire pupillary area, and it causes occlusio pupillae. Now there is something known as seclusio pupillae. So in annular posterior synechiae, it prevents the circulation of aqueous humor from posterior chamber to anterior chamber. So we've discussed that in this diagram here. This flow is blocked, and this blockage of flow of aqueous humor from posterior to anterior chamber due to the annular posterior synechiae is known as seclusio pupillae. So I hope you've understood the difference between the seclusio pupillae and the occlusio pupillae. Okay, occlusion is basically, it is occluded by the exudates, and seclusio pupillae is because of annular the aqueous flow is secluded. Okay, that is because of the annular posterior synechiae, the flow of aqueous humor from posterior to anterior chamber is blocked. So that is seclusio pupillae, and in seclusio pupillae we also see iris bomb formation. So these are the pupillary signs: narrow pupil due to ciliary spasm, festooned pupil, decreased pupillary reaction, and occlusio pupillae may be seen. Now the changes in the lens. Now there is pigment dispersal on the anterior capsule of the lens. There is pigment dispersal on the anterior capsule of the lens, and complicated cataract may be seen. Now the most important, like if someone asks you in complicated cataract what is the two important features, it is breadcrumb appearance of the lens and the polychromatic luster. Okay, so changes in the lens, pigment dispersal on anterior capsule of lens, and complicated cataract. And what are the two important features of complicated cataract? Breadcrumb appearance and polychromatic luster. So these are the changes in the lens. So let's revise the signs of anterior uveitis. So remember, the light passes like this. So we have corneal signs, anterior chamber signs, iris signs, pupillary signs, and changes in the lens. Now the corneal signs are circumcorneal congestion, edema, and creatic precipitates. Then we have the anterior chamber signs, which is aqueous flare, aqueous cells, and hypopyon. The changes in the depth of the anterior chamber. The iris signs: muddy brown waterlogged iris. Iris nodules may be present, and important is posterior synechiae. Then the pupillary changes is pupillary because of ciliary spasm there is a narrow pupil, there is decreased pupillary reaction, and the exudates can come and occlude, so occlusio pupillae. Then changes in the lens, pigment dispersal along the anterior capsule of the lens, and complicated cataract. And the two important features of complicated cataract are breadcrumb appearance and polychromatic luster. So these are the symptoms and signs of anterior uveitis. Now let us move on to the differential diagnosis of anterior uveitis. Now we've mentioned that the two most common symptoms that the patient can come with is pain and redness of the eye. Okay, now the differential diagnosis for acute red eye, sudden onset of redness in the eye, or sudden onset of redness and pain in the eye, is only three. We have, it can be due to acute conjunctivitis, number 2 due to acute congestive glaucoma, and number 3 acute iridocyclitis. So these are the three important DDs for acute red eye: acute conjunctivitis, acute congestive glaucoma, and acute iridocyclitis. Now other differential diagnosis, we have to know whether the uveitis is granulomatous or non-granulomatous, and we can also divide the uveitis due to its etiological causes, that is infectious, non-infectious. If it's infectious, the bacterial, parasitic, fungal, viral. If it's non-infectious, due to autoimmune disorders, collagen disorders, atopic, trauma, etc. Now the complications of uveitis. Suppose we leave the uveitis untreated. What happens? The most important complication is complicated cataract and secondary glaucoma. Now secondary glaucoma, we have early glaucoma and late glaucoma. Now early glaucoma is basically during the active phase, because of the release of exudates. These exudates block the trabecular meshwork, and this causes early glaucoma. The late glaucoma is basically because of seclusio pupillae or occlusio pupillae. The flow of aqueous humor from posterior chamber to anterior chamber is blocked, and that results in late glaucoma. So the complications, the important ones are complicated cataract and secondary glaucoma. Other complications include choroiditis, that is inflammation of the choroid. Then we have retinal complications like retinal scar, retinal detachment, etc. Band-shaped keratopathy can be seen. And finally we have something known as phthisis bulbi, that is soft, shrunken, and atrophic eye. So we'll discuss this in another video. Phthisis bulbi. Okay, so these are the complications. The most important complications, again, it is complicated cataract, secondary glaucoma, and phthisis bulbi. Okay, that is the eyes become completely soft, shrunken, and atrophic. Now the investigations to be done in uveitis. So a number of investigations is done, and uveitis is one of the diseases in which a number of investigations should be done um, because of the various etiological factors. Now, the blood investigations, stool investigations, urine investigations, X-ray, radiological investigations, and we have skin tests. Under blood investigations, we have total leukocyte count, differential leukocyte count. Then we have the ESR, and this is to know the inflammatory response of the body. Then we have serological tests for syphilis, toxoplasmosis. Number 4, we have tests for anti-nuclear antibodies, C-reactive proteins for sarcoidosis, blood sugar levels for diabetes, and blood uric acid levels to know the status of gout. So these are the blood investigations. The most important are total leukocyte count, differential leukocyte count, ESR, serological tests for syphilis and toxoplasmosis, and tests for anti-nuclear antibodies. Coming to the stool examination, we've mentioned that toxoplasma and cysticercosis is a cause of uveitis. So we look for the presence of cysts or ova in the stools. Next is urine examination to rule out any UTIs. Then we have X-rays of the chest and the lumbar spine, and CT scan of the thorax to know the presence of tuberculosis or sarcoidosis. Then we have skin tests like tuberculin test. So these are the investigations to be done in uveitis. So blood investigation, stool examination, urine examination, X-ray of the chest and lumbar spine, CT scan of the thorax, and skin tests. Now the treatment modality, it involves three things: the non-specific treatment, the specific treatment of the cause once the diagnosis has been established, and finally the treatment of the complications. Now the non-specific treatment, that is, if a patient comes to you with uveitis, the immediate treatment to be started is cycloplegic drugs and corticosteroids. So before we go into that, non-specific treatment can also be divided into local therapy, physical measures, and systemic therapy. Under local therapy, the first line of drugs are cycloplegic drugs and corticosteroids. Now, cycloplegic drugs, why? We've mentioned because of ciliary spasm, the patient presents with pain, and cycloplegia is plegia meaning paralysis, cyclo referring to the ciliary muscles, so paralysis of the ciliary muscles. Now, the cycloplegic drugs used are 1% atropine sulfate, 2% homatropine, and 0.25 ml midriasin, which is a combination of atropine, prosaine, and adrenaline. The second is local corticosteroids like dexamethasone, prednisolone, and betamethasone. These are given as eye drops 4 to 6 times a day or as an eye ointment. So corticosteroids, why? Because it is an anti-inflammatory. Because uveitis is an inflammatory process. To suppress inflammation, we give corticosteroids. So again, dexamethasone, prednisolone, and betamethasone. Third, broad spectrum antibiotics may be given as an umbrella cover to the steroids. Next, we have physical measures, which is basically hot fermentation and use of dark goggles. Now, teachers may ask you, how is hot fermentation done? So we tell the patient to boil some water and add some salt to it. We take a warm clean towel, we dip it in the hot water, we rinse out the water, and we press it against the eye. So this is hot fermentation. So remember, salt must be added to the boiling water, a pinch of salt. Now these are the physical measures. Now the systemic therapy for the non-specific treatment is again corticosteroids, prednisolone 60 to 100 milligram. Then immunosuppressive agents like cyclophosphamide may be given, and third is non-steroidal anti-inflammatory drugs, and these are the example of this is oxyfenbutazone. So again, non-specific treatment, we have local therapy, physical measures, and systemic therapy. Local therapy, the important drugs are cycloplegic drugs and corticosteroids. Now coming to the treatment of the cause. Once diagnosis has been established, treatment of if it's tuberculosis, treatment of tuberculosis. If it's rheumatoid arthritis, the specific treatment of the cause is important to treat uveitis. Now coming to the treatment of the complications. Now we've discussed the important complications are glaucoma, complicated cataract, and phthisis bulbi. Now if it's inflammatory glaucoma, then we give 0.5% timolol eye drops with tab-acetazolamide. If it's post-inflammatory glaucoma, then laser iridotomy is the mode of treatment. In complicated cataract is lens extraction, but it is not done if keratic precipitates are present. And finally we have phthisis bulbi, which is basically enucleation is done. So the treatment of the complications, if it's glaucoma, either if it's inflammatory we give timolol and acetazolamide, if it's post-inflammatory we do laser iridotomy. Then complicated cataract we do lens extraction, and for phthisis bulbi enucleation procedure is done. So this is about the uveitis. So we've mentioned the definition, the etiology, the clinical features, the signs and symptoms. The signs, remember, corneal, anterior chamber, iris, pupillary signs, and the lens signs. Then we discussed the differential diagnosis of acute red eye. Then we discussed the complications, the important complications being complicated cataract, secondary glaucoma, and phthisis bulbi. We discussed a number of investigations to be done in uveitis, and finally we discussed the treatment modality. Remember, cycloplegic drugs and corticosteroids. So this is about anterior uveitis.